Excuse me, everyone. We now have your presenters in conference. Please be aware that each of your lines is in a listen-only mode. At the conclusion of the presentation, we will open the floor for questions. At that time, instructions will be given if you'd like to ask a question. I would now like to turn the conference over to Anna Wojcik. Ms. Wojcik, you may begin.
Thank you, Stephanie, and thank you, everyone, for joining today's call. Just as the first note, we are having a few technical issues with the Adobe Connect platform today. So for those of you who haven't been able to join the webinar platform, we do encourage you to keep trying. It's taking a little bit longer than normal. So if you're not able to join on the first time you click the webinar link, please try again. And if you're still not able to join, I know we have a few participants who are just on the audio today. You can go ahead and download the webinar slides from our website. That's the Cohort 9 ICU Initiative website on the CUSP stophai.org. So you can download the slides from there if you're really not able to join the platform. We apologize for those technical issues today. Okay, but to kick us off, so welcome to the March National Content Webinar for the On the CUSP Stop CAUTI in ICU project. Today's topic will be on defining critically ill in the ICU, alternatives to catheters, using the CUSP staff safety assessment, and the Learning from Defects tool to improve safety culture. Before we do get started, we remind you that and really encourage everyone to fill out the webinar evaluation. This ICU project is new, and we are really in need of your feedback to make sure that it's meeting your needs. So at the end of the webinar, or whenever you need to join, if you're not able to stay with us until the end, please click the webinar link and complete the evaluation for today's webinar. We really welcome any feedback and input you have on the portion or the entire length of the webinar that you were able to attend. And we do ask that everyone who is on the line fills out the evaluation. So if you're with 3 other people watching the webinar or 3 other people on the line, we ask that every person who's listening to the webinar fills out today's evaluation. We're really excited to have with us today 3 great presenters. Dr. Randy Garnett is the chairman of the Sentara Norfolk General Critical Care Committee, the medical director of the Sentara Lung Transplant Outpatient Program, and a member of the Sentara Advanced Heart Failure Group. His interests include care of organ transplants, mechanical circulatory support, pulmonary hypertension, and ethical, medical, and surgical ICU care. We also have Cheryl Sheriff, who is the cardiovascular clinical practice specialist at Greenville Health System in Greenville, South Carolina, where she is an educator, a researcher, and a consultant to influence patient care, nursing, and systems. And then finally, we have Emily Pisola, who is the clinical nurse leader in Surgical Intensive Care Unit at St. Joseph Mercy Hospital in Ann Arbor, Michigan. As the clinical nurse leader, Emily focuses on quality improvement and unit safety. She is a unit champion for evidence-based initiatives, including CUSP, assisting in planning and implementation and tracking outcomes. So we're really glad to have everyone with us today. And then just a few final housekeeping items. As you'll see on the platform, for those who are able to join the platform, we'll have the chat box below. So we encourage you to post questions during the presentation. We'll also have dedicated time for Q&A at the end of the webinar. And then on the right-hand corner, there are the materials for today's webinar. So they include the slides for today's webinar and just an informational tool that Dr. Garnett will go over. So with that, I'll turn it over to Dr. Garnett.
Thank you very much. I've been asked to define critical illness and the need for the initiation and discontinuation of Foley catheterizations. I found that to be a very daunting task, as critical illness obviously is different in different places. One of the requests was to define the exact point where the risk-benefit ratio for discontinuing a Foley catheter could be measured and used, and I think we're a long way from that, but because of projects like this, hopefully we'll get a little bit closer. This is obviously a complex issue, and one size doesn't fit all. I think a couple premises to begin with is if we don't need to place a Foley catheter, let's not place one. If one is in place, we need to, once or twice a day, look and see if it is appropriate to discontinue the Foley catheter. And also, just like when we have failed extubations, I think we have to buy into the fact that sometimes we'll be able to put the Foley catheter back in without a whole lot of harm to the patient. So ICU characteristics are very different probably amongst most of the hospitals here. I'm going to speak primarily about our institution. We have 7 different subspecialty ICUs, and I can tell you each one is different. They're both medical and surgical. The acuity level of the patients is different in each unit. Where the patients come from with regards to the floor, the emergency room, the operating room, all puts them at different risk for having Foley's placed either for the right or the wrong reason. Who puts the Foley catheters in is different in each unit, and we have to make strides towards making our care more uniform. Every ICU here, at least, has its own culture. Each ICU is its own family, and I think they handle Foley catheterization differently in different ICUs. And that's more of a historical thing, at least at our institution. The RNs have needs, the physicians have needs, and sometimes those needs are not the same. And now with CMS regulations, the administrators have some skin in the game, and because of the financial issues associated with hospital-acquired infections, and they have become much more robust in trying to change behavior. As an aside, right before I go into just going through these slides, I was on call this past week, and I had 4 cases where I was where Foley catheterization came into question about whether or not it was needed anymore. And that's because we've been very active in educating the nurses and trying to move things forward, and we've got a 48-hour discontinuation protocol. The first patient was a patient who was a status post-surgery who was up eating breakfast, had the Foley in, and the nurse said, well, when the patient gets to the floor, we'll take the Foley out. Possibly could have been taken out sooner. The next one, the nurse at the time of rounding on an ICU patient who had just been extubated and who was fairly alert, we had a collegial conversation. The nurse thought that she could care for this patient without having a Foley in, and the Foley was discontinued. The next patient was a patient who was intubated with a PCO2 of 110, and we were having significant difficulties keeping him sedated. And after the 48 hours, the Foley catheter was removed at about 3 in the morning without any physician input. And as expected, the patient needed to have the Foley catheter put back in, but I learned at that time that putting a catheter back in and giving the chance for a patient who is in and out of consciousness to passively use a condom catheter is an option and that I need to adjust. And then finally, the one I found the most interesting was the head of our hospital was harassing one of the ICU nurses to call the doctor immediately because it was 5 minutes after the 48 hours, and the Foley catheter either had to be reordered or taken out. So it's a new paradigm. I think it's good that we're talking about this, and I'm just going to run through some basic thoughts about critical illness and possibly how we can do this a little bit differently and change the historical habits that we've had in the past. This mainly is our experience here and is not really representative of, I think, everyone's experiences, and please take this discussion in that light. The first is a very difficult slide to see, but it basically has indications for urinary bladder catheterizations, and one of these is urine output in the critically ill patient. There's obviously other reasons to have catheters in the ICU. The bottom talks about the end-of-life care, people with wounds that need to be kept clean, people with GU or neurological problems. And I'll just put that up there for people to look at and possibly learn from. There are other good examples on the CUSP website that can give you more information about this for the future. So let's start talking about patients who are in step-down unit or heading to the ICU who don't have Foley catheters in. And it's what I call this is the potentially critically ill patient in the clinical observations that you see. So this is someone who's ill, who's agitated or confused, who responds but not normally who has multiple signs and symptoms of SIRS, heart rate elevated, blood pressure down, and low urine output. This patient, in my opinion, 5 years ago would have gotten a Foley as one of the first things that we do because we have to do things. And I think this patient may eventually need a Foley, but at the same time, we need to treat the patient and see where they are in 15 or 20 minutes. That moves on to the critically ill patient who has progressed. Sorry, we have a printer going off in the office here. That has progressed to looking very, very ill and hemodynamically unstable. And I think most people in this particular scenario would move towards a Foley catheter fairly quickly. Even in our own institution, I think we have different thresholds as to when a Foley catheter is placed. Multiple system organ failure usually requires Foley catheterization. And then now we're just going to talk about surgical and medical patients in terms of patients that we would normally have Foley catheters in. Surgical patient categories who will almost always have an indwelling urinary catheter are the postoperative patient with continued mechanical ventilation and sedation. Again, this is early on. It doesn't mean that a patient on a mechanical ventilator who is not heavily sedated, who can help you move around in bed, needs a catheter long term. Patients who have had major cardiothoracic surgery, cardiac bypasses, valve surgeries, transplants, dissections will almost without exception come out with Foley catheters in. A major abdominal GI surgery where there's fluid shifts, major vascular surgery, most GU surgeries because of the potential for bleeding and needing to keep the GU tract clean will have Foley catheters. Hemodynamically unstable postoperative patients where urine output helps guide therapy, immobilized patients who have got pelvic fractures and trauma and brain injury, and then also patients with multiple comorbid processes where accurate urine output is important to monitor, such as people with acute and chronic renal failure, people with cardiomyopathy and congestive heart failure and other low cardiac output states. And on the rare occasion, someone with a high urine output syndrome such as diabetes insipidus. Other patients who have postoperative delirium, agitation, and encephalopathy, I think we oftentimes feel that this can simplify their care, although sometimes a Foley catheter is one of the niduses for their discomfort. Medical patient categories who almost always need urinary catheters include respiratory failure or mechanical ventilation, hemodynamic instability with septic shock, hemorrhagic shock from GI bleeds, trauma, and post-procedures, cardiogenic shock, unstable CHF patients undergoing massive diuresis probably need Foley catheters in the ICU, although I don't believe that all patients do. It depends on their level of illness. Patients with severe neurologic impairment with altered mentation after large strokes, intracranial hemorrhages, subarachnoid hemorrhages, traumatic brain injury, etc. Most times will start off with Foley catheters in the ICU, and acute and chronic renal failure with obstruction and retention. I've also seen the rare patient who is not terribly critically ill, but because of BPH or something like that, especially in males, trying to pass their urine, puts them into distress. And again, maybe another reason to use Foley catheters in the critically ill. Types of treatment requiring close urine output monitoring. We all know those things when we're using boluses of fluid for resuscitation, when patients are on vasopressors and inotropes, when we're using high-dose diuretics, and when hourly urine studies to measure life-threatening laboratory abnormalities are important. These are all patients that a Foley is utilized in multiple situations. Again, the important thing is look at the patient, and we're trying to get away from because you're in the ICU, you need a Foley. Look at the patient. You can always put a Foley in later if they progress and get worse. You can always take the Foley out as they get better. And to have a conversation every day or twice a day about getting Foleys out, I think has the most utility, at least in our units, to decreasing the time that Foley catheters in and the risk of CAUTI. So now what we're going to do is go through 4 cases real quickly. There are no right or wrong answers. I think Anna has asked for people to vote yes or no with each one of these. And again, there are no right or wrong answers because I think in our hospital I've seen all of these cases almost have a Foley in or not have a Foley in a 2-week period. So the first patient is 24 years old. They present with acute shortness of breath to the ED. They have a history of asthma and they're acutely ill and moved to the ICU. The blood pressure is a little high, the heart rate's high, the respiratory rate's high. The patient is oriented, 2+ accessory muscle use, and they're diffuse wheezing bilaterally with a very prolonged expiratory phase. They can move from the stretcher to the bed without significant change in their status. Their arterial blood gas shows a mild respiratory acidosis. So I guess the question here is, does this patient need a Foley catheter? And we'll give you 10 or 15 seconds to vote yes or no. Again, this is not graded, and there are no right or wrong answers.
And the poll is on the bottom of the screen. You should all be able to see it and just click yes, no, or not applicable if you're part of HRET or the National Project Team. Randy, are you able to see the votes as well?
I just voted.
Great.
And I voted with the majority, it looks like, so that's good. All right, so let's go to case 2. It looks like we've got a consensus there. So the next case is a 72-year-old male, 48 hours post a cardiac bypass times 3 and an MBR. He is still on he's still on mechanical ventilation with moderate levels of sedation, and we use a RASS score here, and it's -2, which means that the patient will arouse and stay with us for 15 to 60 seconds before he drifts back off to sleep. He's on moderate doses of norepinephrine and epinephrine. Let's just say we use mics per minute here. Let's say he's on 8 of norepinephrine and 3 of epinephrine, which is being adjusted for a mean arterial pressure of 65 to 70. He's on 55% and 8 of PEEP. He opens his eyes, follows simple commands before drifting off. Lung and cardiac exam are normal. Abdomen is benign. His extremities are well perfused. His lab and chest x-ray are not concerning. So once again, let's say whether this person still needs a Foley or not. And votes are still coming in, I can see. And we're almost up to 200.
And that's about where we should be, Randy.
So I'm impressed that about 20% of people said no, this patient may not need a Foley. And I think in a year ago, before I got involved in this, I would have said yes 100% of the time. But I think we need to start thinking about this patient because he will open his eyes and follows some commands. He may be somebody that the Foley can come out before he is completely cured. The thing that concerns me is he's on norepinephrine. Again, no right or wrong answers here. So we'll go to number 3. An 83-year-old male with BPH who is post-op at ruptured AAA returns to the ICU for his post-operative care. Remarkably, has extubated 2 hours post-arrival in the ICU and has only moderate abdominal pain. His drips are low-dose norepinephrine. His vital signs are relatively stable. His physical exam is relatively stable, and he's making 50 to 100 cc's an hour since going to the operating room. Can this indwelling catheter come out? And the votes are coming in a little more slowly this time. People are thinking a little bit harder, it seems. And I guess it was a good question because it's closer to 50-50. And I think this is the type of thing, at least at our institution 2 or 3 years ago, it would have probably been 90% leave the Foley in and 10% take the Foley out. So I think everyone's thinking along the same lines. For our final question, 65-year-old with moderate to severe COPD with acute on chronic respiratory failure in the ICU from the ED and placed on non-invasive ventilation. He does not have a Foley in. He has no cardiac history. His vital signs are relatively benign, with a heart rate of only 110, respirations 21, and only 1 plus accessory muscle use. His breath sounds are distant with rare wheezing and a prolonged expiratory phase. His cardiac exam is pertinent only for tachycardia. His abdomen is benign, and he's oriented ×3, moving around the bed. He's been supported 3 times short-term with non-invasive ventilation in the past year without needing intubation. And ABG on 40% shows that he has a moderate respiratory acidosis with adequate oxygenation. So the votes are coming in a lot faster than I can read the question, and I think most people would agree that this patient probably doesn't need a Foley catheter, but this patient is the one that every time he had to urinate went into respiratory distress in our institution and actually did get a Foley catheter. So I think this shows the diversity of the patient population. It shows the fact that we need to look at critical illness as a journey with a beginning, middle, and end, and that Foley catheters have that same journey. If they're needed, we put them in, and when they're not needed, we get them out. I do not know of a way to stratify for all institutions that particular moment when the risk-benefit ratio changes. I think that's something we'll get better at with time because of this project. And I thank you all for your attention.
Thank you very much, Dr. Garnett. And with that, I'll pass it over to Cheryl.
Hello. I'll be sharing with you our unit's experience with pretty much a nurse-driven indwelling urinary catheter removal protocol. We initially started our CAUTI journey, I'm sure like everyone else, focusing on what are our insertion issues, what are our maintenance issues, development of bundles, and then, of course, our surveillance of those. And we certainly identified many opportunities in both of those categories and made improvements. But when we began to analyze our data, we continued to see more opportunities for improvement. And actually, our practice council, in looking at research and evidence, kind of took this on as a project. And one of the things that we kept finding was information on this nurse-driven removal protocol. So therefore, we wanted to kind of embark and see what an implementation of this how this might impact our CAUTI rates. So of course, our first step was really engaging the leadership. And it takes various levels of engagement. For example, the nurses, physicians, and administrative. In our situation, I really attribute a large degree of our success was that this idea came from the bedside staff. They were engaged in this. They initiated this project, and working together, we moved it up through physician leadership and administrative leadership to get approval to do this as a pilot on our unit. So we started small. We started on one area, and I think that was a key success in our program as well. Actually, when we first approached leadership about this, we found out that it had been discussed in some other committees that were looking at CAUTI reduction. And, of course, one of the biggest barriers and concerns there was from the physician, but there was also a lot of pushback and concern from nurses as well. Certainly nurses were concerned. There were some nurses who said, I don't want to be empowered to remove the Foley because what if something happens? So there were a lot of things like that we had to identify as our barriers and how do we approach and deal with those barriers. So we worked with our medical director, mapped out what we wanted to do. Our medical director supported us in the initiative. The medical director went to bat with the other physicians that admit into our unit and explained to them what our pilot would be, what we were looking for. And then we began to educate our staff and educate, of course, the physicians who would admit into the unit. And we presented some of the evidence that we had found in research where this had been utilized at other facilities and the impact it had had on their CAUTI rates and their patient outcomes. So fortunately, we were able to start the pilot in our unit. Really, with the education, we tried to simplify it. And I will say that, yes, education was needed, but I think the biggest thing that was already pointed out is that this is a huge culture change in critical care. So we got a lot of deer in headlights kind of looks. And when I say that our bedside nurses started this, our practice council only consisted of a few members of our nursing staff. So we were not fortunate enough to have all of our staff nurses engaged at the very beginning. So there again, we really had to work with them and getting them engaged with what we wanted to do with the pilot. So we kind of just put together some information, and we started with really the R's. We wanted to review. We already had existing criteria for indications for Foley that had been reviewed and supported by physicians, and this was really coming from the SCIP measures. But we just translated that over into the care of all our patients and began initially with those same indications. So we began to look and say every shift when we do our GU assessment, each nurse is responsible for reviewing as to whether or not the patient meets those indications for having the indwelling catheter in. If not, then during this pilot, the nurses in our unit were empowered to remove the Foley per protocol. So they simply wrote the order, made it per protocol, and then went ahead and removed the indwelling catheter. We began to see, it took some time, but we did begin to see a reduction in our catheter days with this timely removal, and we began to see a reduction in our CAUTI rates. This slide actually depicts for you the indications that we used. This is not what we initially started with. I think what Dr. Garner was saying earlier about the approved indications for catheter is very unique to each unit, and you have to tweak those, and ours have certainly evolved over time. The one we really focused on was we had a very blanket statement about accurate measurement of intake and output in critically ill patients. And we quickly found that when we would review each patient, discuss with the nurse, so what's the indication for the Foley? Oh, well, I'm marking the indication that it's a critically ill patient. So we worked with our medical director, and we really put some qualifiers on that. And when we put the qualifiers in, that's when I feel we really begin to see the tide turn, and when we really begin to make some strides in getting the indwelling catheters out and reducing some of our CAUTI rates and our device utilization. Again, by no means are these qualifiers perfect. One of the ones that we did tweak was deoxygenation with exertion or position changes, because as we reviewed patients and we looked at the criteria that they were meeting, we originally did not have this one on here. And sometimes we would find that patient who was on a non-invasive ventilator or non-invasive ventilation, and just the work and stress of moving in the bed, trying to use a urinal, or for females trying to get off on the bedpan, they would quickly desat. So, or it could be that patient who had a very rocky course with intubation, very lengthy time of intubation. We finally got them extubated, but it absolutely, would cause very severe drops in their O2 sat. with the stress of using urinal, getting on and off the bedpan. So we went back and really added that qualifier in as well, and that was really based on staff discussion, again, going back to our medical director and presenting some of the things we were finding with our daily review. The other way that we implemented this is we do care rounds each day. So this became one of our main focus during the care rounds, was really focusing on our patients who had Foley's. And with each nurse, either individually or with a group of nurses all around, we would review the criteria and apply that to that specific patient situation. We would kind of discuss together, does this patient really meet the criteria for us to go ahead and implement our removal protocol? I think this was very beneficial because it helped to ensure that the protocol was actually followed. It also sent the message that this is an expectation of all nurses, that this is now our culture in critical care. But I think one of the most important things is I really think it helped engage some of the nurses who were more skeptical about this, because we could really validate patients who were being identified as, yes, you're correct. This is a patient where it's appropriate for you to go ahead and remove the Foley per protocol, or no, I agree, this is a situation where we need to hold off. We need to have a physician discussion about this patient. Because really one of their biggest fears was being empowered to do this and then removing the Foley and having to reinsert it for some kind of catastrophic reason. One of the other challenges that we found is that really going back to the surgical patients, there were some surgical patients, and we felt like even though our criteria was there in the indications for which patients the indwelling catheter needed to remain, there was still some concern from certain surgeons, particularly urologists. And so one of the things that we have implemented is if it is a Foley that's inserted in the OR, and the surgeon does not want us to use the nurse-driven protocol or the protocol for removal, they can actually tag it in the OR with the yellow band. And that is a visual to us that that patient falls out of our protocol. There are some workarounds with this, and we found there was a workaround in our cardiovascular ICU and our post-bypass patients that the cardiac surgeons were actually tagging all their Foleys with that. So we went back and had a discussion with them, and so now they have changed that practice, and they are on board with what we're doing. So we started, as I said, in one critical care unit in our CCU, and based on the data that we were able to present, we have now rolled the protocol out to all of our other intensive care units, and they're beginning to see some of the same reductions in device utilization. Some of the other particular patients that we found questions about was, and we kind of did what we called a factor fiction with the nursing staff. One of the questions was that any patient on Lasix really needs to require accurate intake and output, and the only way you can get that is with an indwelling urinary catheter. So again, we just reiterated with them that that is a case-by-case basis, and not every patient who's receiving Lasix IV has to have the indwelling urinary catheter in. Even some of our cardiologists were very supportive in that and saying that really they were more concerned with the weights on that patient more so than the intake and output. One of the other factor fictions, again, is all patients in critical care require an indwelling urinary catheter for accurate measurement of intake and output. Again, I think as we've all mentioned and have experienced, this is probably one of the biggest things because it's a culture change. So we really begin to encourage them, the qualifiers that we put in place, and as I mentioned earlier, we continue to revisit these and tweak these as we go along in our process. The other thing is that critical care patients who are admitted from OR and PACU, they don't automatically need to keep the urinary catheter in. So it goes back to that daily review of what is the need on this particular patient. So again, some of the lessons learned, I've already mentioned the culture change, that it requires a daily focus to initiate and sustain this kind of initiative. One of the other lessons learned is collect your data. Review the number that are removed per this protocol, and then look at the number of those that require reinsertion. This is how we were able to take the data from our pilot, roll it out to other units. This really helped us overcome some of the physician concerns with this being protocolized. And then also document what the reason for reinsertion is, because again, if it's just that they failed the urinary retention protocol, that's kind of different than another issue for it being reinserted. So again, just to kind of close up, to end my session, this kind of came from the bedside caregivers. They were very engaged in doing this, and it has helped impact our device utilization, and as a result has helped us reduce our CAUTI rates. And I thank you for your attention and welcome any questions at the end of the presentation.
Great. Thank you so much, Cheryl. Emily?
Yes.
Great. We'll let you get started. Thank you.
Yep. Okay, so today I'll be discussing how to identify defects and using the Learn from a Defect tool. And then I'll just review an example of how we've used it here at St. Joe's in Ann Arbor. So really a defect is anything that you don't want to happen again. And in many cases, the defect may be something that has caused patient harm or has the potential to cause harm. Specifically, the events listed here on the slide are things that can be considered defects, or they are defects in our facility. And so for events like CLABSI, CAUTI, or VAE, each month we review charts of these patients to try to find themes to help the Learn from a Defect process along. Other defects can include environmental factors, so things like staff safety concerns or issues related to staffing or patient acuity. So there are several strategies that we have here that we've used to help identify defects, and talking to the frontline staff has probably been one of the most beneficial. So the bedside staff really are the eyes and ears of the unit. For example, every day we do shift huddles during every shift, and we talk about a lot of outcome metrics and educational topics, but each shift we also try to discuss the climate of the unit. And so we ask staff if they have any safety concerns or anything that's bothering them. And if there's something that we need to talk about, we talk about it then. So this is a time during the huddle to quickly talk about how things are going. Other strategies are learning about defects in staff meetings, and leader rounds are another way. Directly asking staff, do you have everything you need to do your job? What are your safety concerns? And then there's also times that it's been identified right in the moment or right after they happen. So, when people perform a medication error or a new hospital-acquired pressure ulcer is found. So we also have an anonymous electronic reporting system that allows our staff to enter information about events that occur. And they can really be anything related to communication breakdown or ethical concerns all the way to patient falls and pressure ulcers. And lastly, monthly data reports also help us to identify themes or trends. So, for example, if we're not meeting our goals of resuscitation with our septic shock patients, so like timely antibiotic administration, so that we could consider a defect, and it's something we can investigate. So, but finally, the staff safety assessment can really allow staff to think about and dive into concerns that they have. This is an example of the staff safety assessment. So really you can format it to your unit's needs or even add questions to it. Last year, our ICU, we asked an additional question about that was specific to patients receiving mechanical ventilation, and we asked for feedback about that specific population as well. But really, the staff safety assessment is focused on the staff answering two questions. So the first, please describe how you think the next patient in your unit or clinical area will be harmed. And the second, please describe how you think that what can be done to prevent or minimize this harm. So again, the reason why this is important is because we want to engage staff in our work around safety and being transparent about how their ideas and their feedback influences our action plans and the solutions around those defects. So again, we have taken our staff safety assessments in the past and we collate all of the results. We share the results with staff. We share with them what the major themes were, and then we ask them in different venues to help us develop action plans related to that. They should really know what we're doing to help fix the defects. So when we're talking about defects, we use the Learn from a Defect tool. It really helps to support our culture of safety. It's a very easy tool to use. It's efficient. It's very structured. And it also provides a venue to talk about defects in a non-punitive way. So we want to focus more on system and process issues versus personal performance. When we do learn from a defect, it can happen in a variety of settings, but it helps to build collaboration among the team, and it can also be multidisciplinary. The one thing that I've liked about it is that sometimes it brings frontline staff together with other members of the team that they may not get to work with on a day-to-day basis. So as I said, the Learn from a Defect strategy can be brief, and this slide shows an example of a badge card that we have here available. And again, using the shift huddle as an example, most recently we used the Learn from a Defect process to discuss an equipment issue. We had a patient situation where staff were unaware where some emergency equipment was kept, and it's because the sterile equipment was wrapped in a different color of wrapping than it had been before, so it wasn't able to be identified during the emergency situation. So we ran this problem through the Learn from a Defect process. The outcome of that situation was okay because we had additional equipment on the unit, but we decided through this process that we needed to standardize where our equipment was set so that we could clear up the confusion. And we didn't focus on at all personal performance. It was all about the fact that there was a problem with the system. We didn't have things standardized. So by consistently using this process with the staff, we want them to begin to use this on their own when they're talking about defects on their own. And then lastly, this is an example of the Learn from a Defects worksheet that we have here at St. Joe's. And we, as I said earlier, we use it on a variety of things, including CAUTIs. So every month we will get a report if we had any CAUTIs in our unit. And so there's a thorough chart review done, and then we try to find major themes among those patients. Learning about why did it happen, seeing if we can figure that out. What we could have done to prevent it, what happened to cause the defect, and then we develop action plans. And so the nice thing about having this kept in one place and having it kind of organized in this fashion is that it's one central location for people to go back and look at to see when updates are needed, what our targeted dates for completion are for different action plan items. And it just overall helps support accountability and kind of just keeps things consistent, keeps us on track to meeting our goals. So overall, Learn from a Defect is very easy. It's an organized approach to resolving defects that we've identified. And again, it really encourages engagement from frontline staff. It helps them to voice their thoughts and ideas that can be shared with the multidisciplinary team. So having a clear action plan that identifies responsible parties and target dates for accomplishing tasks, it all establishes accountability among team members, and it helps us track outcomes that will help make meeting goals more meaningful. And that's it.
Great. Thank you very much, Emily. So I think we'll move on to to our Q&A portion here. I do want to remind everyone to, once again, to please make sure you fill out the evaluation link. It's on the screen right now. So if you're not able to stay for the entire Q&A portion or you just wanted to fill out the evaluation now, we do really appreciate that feedback. And so, oops. So with that, Stephanie, could you open up the Q&A portion?
I sure can. At this time, we will open the floor for questions. If you'd like to ask a question, please press the star key followed by the 1 key on your touch-tone phone now. Again, if you'd like to ask a question, please press star 1 now. Our first question comes from Susan Cannon with North Carolina.
Thank you. Hi, Cheryl. This question's for you. How long after the vasopressors are stopped do you guys allow for them to keep a Foley in for potentially needing to restart it?
Is Cheryl still on the line?
I'm sorry, yes. We don't really have a definitive time frame. I think this is where some of the case-by-case analysis comes in. It's looking at the patient, how long have they been on the vasopressors, have they had a rocky course and that has been stopped and restarted. We might allow them a longer time to stabilize. If it's someone who has had, a relatively stable course, short-term vasopressors, blood pressure's looking good, probably earliest is a couple of hours.
Okay, that helps. Thank you.
Our next question comes from Donna Boatwright in Florida.
Hi, this question is for Dr. Randy Garnett.
Okay.
Dr. Garnett, are you still on the line?
I still am.
I would love to know about your 48-hour protocol to receive Foleys.
Honestly, I just found out about it last week. It was developed by some of the nurses in our burn trauma and neuro ICU. I've just got a copy of it the other day. I think some of the comments that Cheryl just made are very important in that if every patient is different and you have to use clinical judgment, and I think each system needs to come up with a nurse-driven protocol that makes sense for that particular unit. But at the same time, it pushed me as a physician who's old and has done the same thing maybe the wrong way for 25 years to at least think it through again. And I think we need to push the physician side of this because we tend to want to control everything. Sorry I don't have an answer about the exact protocol, but I can try to get it for you if you would send me an email.
Could you put your email address on the chat?
I can try.
Okay, thank you.
Right, thanks.
Our next question comes with Anna Vance in Florida.
Yes, this is actually Marguerite Salinas-Watt and Anna Vance and Richard Cox, the three of us. And the question I was going to ask was, I see there's considerable amount of paper tools to have feedback. What is your success rate on those, getting those back to assess them and then maybe collect data to see where that trend is going with your staff huddles and that paper to be filled in?
I think you're asking that question of Emily about the staff safety assessment.
That's correct.
Okay, Emily, are you on the line?
I am, but things we're kind of cutting out. Can you repeat the question, please?
Certainly. I see from the tool that you anticipate feedback. What is your success rate on your tool, the success rate for the completion and return for appropriate data collection, and how you're able to trend for the safety when it is on paper as we hopefully move away from paper?
So, I don't have an exact number of how many nurses or staff members responded last time, but we do try to make it a situation where the surveys are available, and if staff need, 10 minutes away from their assignment to fill it out, one of the leadership members on the team or on the unit that day will provide that time and watch their assignment for them.
Mm-hmm. So you're pretty much getting your paper back, your tools back, your surveys.
Yep.
Wonderful. Okay, something to think about. Thank you.
And this is Tina, and just to put this out there, these tools are used by many, many hospitals now across the country, and they use them for many, many different quote-unquote defects. So they might use them for falls if that's their focus for the month, or med errors, or CAUTIs, or whatever is the issue. Many staff will use them as a sort of icebreaker for a staff meeting, and they just pass them out, and they collect them up, and then they give a minute synopsis at the staff meeting about what were the major group of problems identified, and then the team has the opportunity then to respond to those identified needs. And some people don't have the development of their team to do all the problems identified, but can, in fact, prioritize the problems that are identified and obviously look at acuity and frequency of those issues and address the most important ones first as far as patient safety are concerned. Many other nurse leaders are starting every meeting with those two questions.
Thank you.
Our next question comes from John in South Carolina.
Yeah, this question is for Cheryl in Greenville. Cheryl, I have a question about your care rounds. I'm curious as to how often do you do this and how long, and who are the interprofessionals that are involved in your care rounds, and how many patients do you see? Because we seem to struggle with this quite a bit. Also, I'd like to know more about your process to engage your physicians. I think what you did with nurse engagement was very clever and was very smart. I'd like to know more on the physician side, how you engage them in this process.
The way that we do our rounds is we actually have a version of interdisciplinary care rounds. However, with our unit, we're a 28-bed unit. We have multiple physicians, as I'm sure everyone does, seeing the same patient. So there was really no way we could get the physicians to participate in those rounds. What we have in our conference room is we have a board, and we update the board every shift. We have every patient's name, and we have a category for each of our quality measures. So we have a category, for example, for progressive mobility, for daily sedation, vacation, and awakenings. We have an area for progressive mobility. So each day we start rounds. For example, on day shift we start at about 9:45. We do about the same time on night shift. Each nurse comes in, discusses with our supervisor, nurse manager, or myself about their patient, and we go over the quality measures. We stress that this is not another shift report or an update on our patient. We're really looking at what are the needs of this patient and transferring them from critical care, what are our barriers to doing that, and what are some avenues, what are some things we can be doing. So that's really where we started with the Foley. So we added that category to the board, and when the nurses came in to discuss their patient, we would say, does your patient have a Foley? We had the list of our approved indications there. We would review them with each nurse, and then we would make a decision, yes, this patient meets the protocol for the nurse to remove the Foley, or no, they don't. Or if we weren't quite sure, that is one of the things we would kind of write down, and that kind of helped us refine our indications because we would follow up with those and discuss with our medical director. So that's how we approach our rounds. So again, the people who participate are supervisors, the charge nurse. They're the ones who really lead the rounds. The nurse manager usually attends the day shift rounds, and I drop into the rounds as often as I can. I really, as we were rolling this initiative out, I took the lead for the rounds, being the clinical person, because this was a new clinical initiative, and I wanted to be there to really discuss it with each nurse and get their feedback. And then gradually I transitioned that back to the supervisor, charge nurse, and the nurse manager as leader of those rounds. And they have continued to be able to sustain that. Physician engagement, I have to give credit to our infection preventionist and also to our medical director, because as we began to look at the data that we were seeing from our pilot, and knowing the only thing we were doing different was implementation of the indwelling catheter removal protocol, we began to see some steady reductions in our device utilization. Probably the downside to that is that as you decrease your device utilization rate, sometimes your CAUTI rate will actually look a little worse. And that was a bitter thing for our staff to have to look at. And they're like, wait a minute, we had the same number of CAUTI instances as the other critical care unit did, but just because our days are lower, because we're getting the devices out earlier, we get dinged on our overall rate, and our overall rate looks worse. But that began to kind of come together, and now we're consistent. So that is something to keep in mind that you will see in your data. But I believe with the presentation from our infection preventionist and sharing it in the committee groups and the system groups that they were in, we were asked to come and share our experiences. And again, the medical directors of the other critical care units wanted it rolled out to their areas as well. So I think it's the data. One of the first questions we got asked when we rolled it out was, how many have you had to reinsert and how many have the nurses removed per utilization of the protocol? That's why I included that as a lesson learned, because we really did not formalize that. Hindsight's 20/20. And I don't know how we overlooked that, but we did. And so we had to we went back and had some patient information that we could pull from to get that information. It's a very small percentage of patients that had to have it reinserted. The ones that did require the reinsertion, the most common cause was because they failed the urinary retention protocol and not for any kind of adverse reason.
This is Tina, and I would just let you know, folks, that there are studies on this question out there, and the studies have demonstrated that reinsertion has been lower than all usual expected numbers, and that depending upon how you structure your acute urinary retention protocol, some hospitals are using different bladder scanner volumes to reinsert the catheter. Others are just doing straight caths and then waiting again 4 to 6 hours and seeing if the patient can void spontaneously. Some hospitals are going to 2 or 3 straight catheterizations before the catheter is reinserted if it's just because of retention. Now, if the patient worsens or needed, increased support, whether it be ventilation or inotropes, then yes, they could get a new Foley for that reason. But if it's based on the acute retention protocol, just so you know, they are moving away from just reinsertion. But those data are very helpful to demonstrate as you spread to other services or other physician groups or other units that this was not a problem. The other thing that your yellow tag, your Foley tag with the yellow band, that's a great idea. I really love that. And I just want you to know that some other hospitals have also had an opt-out portion of the nurse-driven protocol orders so that the physicians can opt out in an order, written order. So I don't know if you considered that.
With it, but that is something that that gives me something to consider.
Thanks, everyone. So I have 3 o'clock now. Cheryl and Emily and Randy, I know that it's at the hour, but if you're able to stay for a few more questions.
Happy to.
Yes,
great.
I can.
Okay, great. Thank you both. So Stephanie, do we have any?
Our next question comes from Ellery Archer in Colorado.
Hi, we were wondering if anybody has found an increase in their CNA hours needed with the removal of the catheter.
We do not have any unlicensed assistive personnel in our unit. We are an all RN team. We've not really measured that from the nursing care perspective. We certainly do have probably more frequent linen change. I know that there's a lot of institutions that have found some better incontinence pads. That was one of the barriers, and certainly one of the things when we presented it is that we're not going to be doing anything all day but changing linen because of incontinence. But we continue to stress that, you know, the alternative to that is leaving an indwelling catheter in, putting your patient at risk for an infection. And we emphasize the alternatives to the indwelling catheter. And when those were presented as barriers, we just again reiterated options for alternatives.
Did you look at an increase in any pressure ulcer problems or skin problems?
We have been monitoring our pressure ulcer rate in conjunction with that, and we have not seen an increase.
Thank you.
Thank you.
Great. Stephanie, are there any other questions at this time?
There are no more questions at this time.
Okay. Well, thank you, everyone, for joining us today. Again, just as a summary of today's webinar, the next steps of everything that we reviewed. After today's webinar, you should be able to understand the HICPAC indications for urinary catheter use, especially in the critically ill population. You should be able to understand when catheters may be discontinued in critically ill patients, know what alternatives to indwelling urinary catheters are available in your organization, and how to implement the Learning from Defects tool and the staff safety assessment within your ICU team. The Learning from Defects tool and the staff safety assessment are part of the CUSP toolkit, and all those resources are available on the website. So please be sure to check there for more information on that. And we will post them as well with the slides and the recording of today's webinar. And just one final plug for our evaluation. Please be sure to complete that. We do value your feedback. And thank you to all of our presenters and for everyone joining us today. We look forward to talking to you again next month. Thank you.
Thank you.
Thank you, ladies and gentlemen. This concludes today's conference. You may now disconnect.